Hello and welcome to Alterations in Digestive Function. Here we're going to talk a little bit about the anatomy and physiology of digestive function and then into some of the specific types of alterations you're going to see in your patients who have digestive problems. So first of all, let's just kind of go back and review a little bit here as to what is happening in the digestive system. As we move through the digestion, what is being absorbed, what is going to be digested, and where. So starting out, obviously the food's going in the mouth, going down the esophagus into the stomach, and it hits the stomach, and we're going to be absorbing water and alcohol at that point. Then into the duodenum, where we start to absorb some of our electrolytes, our proteins, vitamins, etc. Now down into the small intestine, where we're starting to absorb our sugars, so our carbohydrates and our proteins are being absorbed, and then into the ileum, bile salts and vitamin B12 and chloride, and then lastly in the colon, where we reabsorb water. So we have kind of this very fluidy type of mix that's going through the rest of the digestive system, and it hits the colon, we reabsorb our water and electrolytes and make more of a solid type of matter before it's excreted from the body. So let's go ahead and let's take a look at some questions about our digestive system. Number one, the nursing faculty is discussing digestion and indicates it begins in the mouth with the salivary amylase that initiates the digestion of. So if you said B, salivary amylase, initiates the digestion of carbohydrates, you were correct. Protein digestion occurs in the stomach, or starts occurring in the stomach, actually in the duodenum, and is influenced by pepsin. Fat digestion is aided by bile. Amino acids are not in the digestive process as far as removing these products from the intestine, but later broken down from proteins. Our next question. A new drug is being tested that is known to inhibit parasympathetic nervous system activity. It is expected that the salivary glands will become. So if you guessed B again, inhibition of the parasympathetic nervous system would result in decreased hypoactive functions of the salivary glands. The individual would experience a dry mouth. The parasympathetic system stimulates digestion, so inhibition of the parasympathetic system is going to decrease the amount of digestion we have, and in turn, the amount of salivary flow we get. The third question is the nursing student is teaching a class to second graders. The student would correctly identify that food moves down the esophagus via a process termed. If you answered A, correct answer, swallowed food is moved from the esophagus to the stomach by peristalsis. Let's take a look at another question. For a patient experiencing esophageal reflux, the nurse would expect which sphincter to be malfunctioning? The correct answer is letter B. The lower esophageal sphincter keeps food from refluxing into the esophagus, so it helps to keep food in the stomach rather than refluxing back up into the esophagus. So we try to make it a one-way street here. The next question is, a patient asks how the GI system works. The nurse would identify that autonomic and hormonal control are involved in GI motility and Correct answer is D. Autonomic control is involved in digestive enzyme secretion, not in defecation, not in swallowing or mastication. Mucus production to form the mucosal barrier in the stomach is stimulated by the release of. Correct answer is C. Prostaglandins protect the mucosal barrier by stimulating the secretion of mucus and bicarbonate and by inhibiting acid. Okay, let's talk about another sphincter here. Which sphincter prevents the reflux of digested material from the colon into the small intestine? Well, if you guess D, the ileocecal valve prevents reflux, then you guessed the correct answer. All right, let's take a look at another one here. The blank reflex initiates propulsion in the entire colon, usually during or immediately after eating. It's the gastrocolic reflex that initiates propulsion in the entire colon, usually immediately after eating. Which information indicates the nurse understands digestion? During the cephalic and gastric phases of digestion, a gallbladder contraction is mediated by the branches of the. It's the gallbladder contraction is mediated by cholinergic branches of the vagus nerve, not the sympathetic nervous system or the somatic nerves. Sympathetic nervous system is that fight or flight response, so that's going to increase your heart rate, your cardiac output, etc. And the somatic nerves are they're innervating a muscle. When we talk about soma, think of muscle. Which sphincter, when it relaxes, allows bile to flow into the duodenum? If you answered B, the sphincter of Oddi, you are correct. When the sphincter of Oddi relaxes, bile flows into the duodenum. The patient asked the student to explain what the GI tract actually does. The student would be correct in telling the patient the GI tract performs which of the following processes. Now select all of them that apply. So the answers are A, B, and D. The GI tract carries out the ingestion of food, the propulsion of food, the secretion of mucus, water, and enzymes, mechanical and chemical digestion of food particles, absorption of that digested food then into the bloodstream as amino acids and other products that can be used then for building blocks and to run the body, and then elimination of the waste products by defecation. Well, I hope that review of our anatomy and physiology was helpful. Let's talk about some specific problems that occur with the digestive system. First of all, let's start out with some of the clinical manifestations. So what can we expect to see is signs and symptoms of a patient who has a GI dysfunction. First of all, anorexia. very possible that when a patient has a GI problem, they're not going to really feel a whole lot like eating. So the GI problem is most likely going to cause the person to feel very much unlike eating. So it's a lack of hunger, despite the physiologic stimuli, or despite the physiologic need. So you can see somebody maybe who has actually lost quite a bit of weight. We see this in patients who have Crohn's disease. They lose quite a bit of weight due to their disease process, but they're not really hungry to eat. And part of that reasoning would be is because when they eat, it's going to stimulate the colon. The colon is then going to contract and cause more pain. So it could be kind of a combination thing here. They're trying to avoid pain that's causing the anorexia. However, we still call it anorexia for any etiology that's causing the lack of desire to eat. Vomiting is a forceful emptying of the stomach. Now, this is a protective mechanism. Back in the old caveman days or whatever, if we're out eating berries and we pick the wrong berry to eat, the idea is the body's going to be able to get rid of it before it is absorbed and the patient would end up dying. So that's the idea behind having vomiting, is a forceful emptying of the stomach. Let's get rid of that stuff so it doesn't get a chance to start to be absorbed. Several types of stimuli can initiate the vomiting reflex. Nausea, kind of a precursor usually to vomiting, is a situation where the patient has a subjective feeling. So like pain, it's subjective. You can't look at somebody and say, oh wow, that person's got nausea. You may see they're uncomfortable. You may see that they don't look very good. But nausea is going to be the subjective feeling that the person is feeling. Now vomiting is then the actual objective thing that we see happening. Hypersalivation is very common before the person has vomiting. So with the nausea part, we might see a hypersalivation and maybe some tachycardia. Retching is a non-productive type of vomiting, and projectile vomiting, this is a very forceful kind of vomiting where the patient actually projects that vomit out, and it can be for a significant period or a significant distance. This happens oftentimes in infants who have problems like intussusception and other kind of problems with the GI tract. Constipation, a very common problem in our society because of our low fiber diet, and other societies don't have such a big problem with it because they have much more fiber in their diet, but we don't. So we have a lot of problems with having constipation in our population. So there's a number of different things that can cause that, but and when we're talking about here is we're talking about infrequent or difficult defecation. So the amount of defecation that people have is going to differ from person to person, and the amount of bowel movements that they have, and it's going to differ from person to person. So constipation is to some extent going to be subjective as far as how infrequently means to them. So there's neurogenic disorders, obviously, that can cause this to happen, functional mechanical conditions, and a low residue diet. That's what we're talking about here with most of the people that we see in our society having problems with constipation. Excessive use of antacids can cause constipation. Antacids usually have a calcium base to it or some other kind of base that can start to cause the stool to become kind of hard. And also antacids can absorb some of the fluid that's in the GI tract into that antacid and make for a hard stool. Diarrhea, just the opposite. Now we have an increased frequency of bowel movements. Typically, this is going to be the kind of situation where the patient has a bowel movement that's watery. Loose bowel movements typically are not considered to be diarrhea, more along the lines of just considered to be a loose bowel movement, which can be caused by having a very high fiber diet. We can end up with loose bowel movements. But diarrhea usually indicates that there's some kind of a problem in the GI tract. This is, again, a protective mechanism like vomiting. Vomiting is a protective mechanism that kind of tries to get rid of that substance before it gets down into the GI tract. Well, this stuff already got down into the GI tract. Now the lower GI tract is going to kick in and it's going to initiate diarrhea. So what happens is that stuff just kind of runs on through that GI tract without being absorbed very well, and that's what causes diarrhea. One of the main problems we have with diarrhea is that so much fluid. Now remember, when we looked at that GI tract before, the colon is supposed to reabsorb water and electrolytes. If this stool is running frequently, very quickly through that bowel, there's not enough time for fluid and electrolytes to be reabsorbed in the colon, and that's why we end up with a watery bowel movement and diarrhea. But on the other hand, we're also losing fluid and electrolytes from the patient's body. So be careful with that, especially in children. Children can develop hypovolemic shock as a result of having fluid loss from diarrhea. Abdominal pain, okay, this is going to be one of the primary symptoms that people are going to have when they have any kind of gastrointestinal problem. So the patient presents to the hospital or the doctor's office complaining of abdominal pain, and then we're going to have to do a little bit more research and find out what it is that's causing that pain. So the patient can have what's called parietal pain or visceral pain, or the patient can have referred pain, sometimes pain from the GI tract. The little pain receptors in the GI tract are not really good. It's not like your fingertip. Your fingertip's got good pain receptors on it. But the pain receptors in the GI tract are not very good about localizing where the pain is and what it feels like. So it can be referred somewhere else. A common situation where we have this is we have pain referred up into the shoulder, specifically either the right shoulder or left shoulder, depending upon the condition that the patient is exhibiting. Gastrointestinal bleeding is another type of symptom that we may see as a result of one of our GI problems. Upper GI bleeding can occur in the esophagus. This is very true of people who have esophageal varices. It can also occur in the stomach or it can occur in the duodenum. When we talk about people having gastric ulcers, we're talking about people who have ulcers in the stomach or duodenum. The lower GI tract can bleed as well. Now, typically, if we have upper GI bleeding, the patient is going to be vomiting blood, and that's called hematemesis. If the patient has blood that's coming out the other end, that's called hematochezia. And if we have just discolored stool, it's called melena. Now, let me tell you the reason why these things would be different named. If we're bleeding from the upper GI tract, say for example your patient has got an ulcer in their stomach and the patient is bleeding, they vomit up the blood that's in their stomach, that's still going to be red blood. Okay, it hasn't had time to digest, it's just going to be red blood. But in the lower GI tract, oftentimes we may have time for some of that blood to digest. Let's say that the person with the upper GI bleed, he's got this ulcer in his stomach, doesn't vomit the blood. Instead, the blood goes down through the GI tract. Well, what will happen is as it's going through the GI tract, it's going to be partially digested. And when that happens, it's going to change the stool from being brown to either being a maroon color or being black. That's what we call melena, as we're seeing that maroon color or that blackness to the stool. If we're actually having blood in the stool, that's called hematochezia, and that's usually an indication that we have a much lower GI bleed in the colon or in the rectum. Occult bleeding is bleeding that we can't see. So we're not seeing a change in the stool, we're not seeing any vomiting or any other reason, and we're not seeing any other evidence, I should say, of bleeding. However, we can test for this. Take a little bit of stool and we put it on a little card and we put some developer on there, and then we can watch it, and that card will turn blue if the patient has occult bleeding. Now, occult bleeding would be a small amount of bleeding in the stool that you can't see with the naked eye. Dysphagia is difficulty swallowing. It can be caused by mechanical obstructions or by functional obstructions. So we can have functional obstructions of the upper digestive system, or we can have mechanical obstructions like a tumor or something like that that's causing the patient to have difficulty swallowing. One very common situation where we end up having a patient have dysphagia is when a patient has a stroke. A CVA is a cerebral vascular accident that is a stroke, and that can cause the patient to have difficulty swallowing. That's a big problem because that means if they can't swallow adequately, they could aspirate the food particles into the lung, which could cause either an airway obstruction and death, or it could cause an aspiration pneumonitis. A very common GI problem is gastroesophageal reflux disease, GERD. So you may hear this, you may see this written in your textbook as GER or GERD, and a very common situation. There's been some estimates that about 70% of the population has some amount of GERD, some amount of reflux. That's why all of these ads are on TV for things like Pepcid and Prilosec and Nexium and all those other kind of medications that decrease the amount of stomach acid and decrease the amount of reflux disease that we see. So we're having reflux of acid and our digestive enzymes from the stomach back up into the esophagus, causes a little burning on the inside of the esophagus. Remember, acid is not supposed to be up in the esophagus because we have our sphincter there, right? So we're not supposed to be having any kind of acid getting up into the esophagus, and it is, and now it's kind of causing a little bit of burning in there, and then that's what's causing the person to feel the pain. So we call that heartburn. There may be some regurgitation where the person feels like they are actually regurgitating some of the stomach contents, or abdominal pain within an hour of eating. So here are some of the mechanisms that could cause a person to have GERD. We can have impaired esophageal motility. Now, when you eat and something goes into the mouth, it's going to go down the esophagus. It doesn't just go down the esophagus by gravity. Gravity certainly helps, but it also goes down the esophagus because the esophagus has motility, and the esophagus is going to contract and it's going to squeeze that food down the esophagus toward the stomach. We can also have a defective mucosal defense in the esophagus. So even just tiny little bits of acid that normally wouldn't cause a problem are going to start to erode the inside of the esophagus. The lower esophageal sphincter could have a dysfunction as well, so that we're allowing contents of the stomach to reflux back into the esophagus. We can have, again, the reflux of the gastric contents into delayed gastric emptying. So let's say that your patient has a delayed gastric emptying. When the patient eats, the stomach starts to fill up and fill up and fill up. There's no place for stuff to go because there's delayed emptying, and it starts backing up into the esophagus. Kind of on a similar note then would be intestinal obstruction. Obstruction of the intestine can happen for a variety of reasons. We're going to look at some of those in just a moment here. But it prevents the flow of your chyme through the intestinal lumen, so we're not getting our stool going all the way through the intestine, all the way to be excreted. So we have some kind of obstruction happening here. We usually classify them as being either partial or complete, simple or strangulated. So a simple type is just a mechanical blockage where we're just blocking the intestine, and it's fairly easy to be able to overcome. A complete type of a obstruction means there's no flow past that obstruction. Partial means there's some flow past that obstruction. A complete obstruction or a strangulated type of obstruction are going to be situations that we probably need to go in and take the patient to the OR to correct. So here are some different mechanisms by which the patient can have a bowel obstruction. At the top, what we're seeing here is a herniation of the bowel into a hernia. So the patient actually has a hernia, so they may have an umbilical hernia or an inguinal hernia, and the bowel has herniated. It has pushed into that hernia. So the bowel pushes into the hernia. Now the hernia, see on either side of that bowel now, and that little pocket we have at the top there, there's muscle. And the muscle starts to, as the bowel gets in there, now it's going to be irritated, it's going to cause muscle contraction. The muscle contracts, squeezes around the bowel, pinches it off, and that's called a strangulated hernia. So that would be a bad situation because the blood flow to that bowel will start to decrease. We'll get ischemia, injury, and necrosis of the bowel, and we could actually have a bowel infarction. The next type, letter B, that's shown there, is showing an intusception. An intusception is one section of bowel invaginating into another section of bowel, and then that decreases the lumen size inside the bowel and can obstruct the bowel. This happens more often in infants than it happens in adults, but still possible in adults, especially in people who have some kind of bowel type of disease, so Crohn's disease or inflammatory bowel disease and things like that. The third type that's listed there, letter C, is showing the bowel kind of twisting around itself. The bowel is almost constantly in motion. Remember, we have peristalsis going on all the time, and that peristalsis is moving the bowel. The bowel's in motion. So with the bowel in motion, it could twist, and it can actually end up twisting around itself and then causing an obstruction. And the last one, letter D, is actually showing the most common type of bowel obstruction we get, which is just that bowel is going to wrap around some scar tissue. About 60% of bowel obstructions occur because the bowel has wrapped around scar tissue that is formed in the abdomen. Now, scar tissue forms in the abdomen because the patient has had previous abdominal surgery. So look for that history of previous abdominal surgery to find a lot of your bowel obstructions, because about 60% of the time that is going to be the etiology. All right, let's take a look at a few more questions then. A 52-year-old patient presents with bleeding from the rectum. This condition is referred to as. If you answered letter C, you're correct. Hematochezia is bleeding from the rectum. Melena is that black or tarry. Okay, tarry being kind of a looser, more watery kind of stool that looks like tar. I mean, it actually comes out looking like tar. It's dark, almost black or black in nature, and it comes out very thick but loose. Occult bleeding is hidden, and hematemesis is vomiting blood. Okay, let's take a look at another question then. A 40-year-old female presents complaining of pain near the midline of the epigastrum. Assuming the pain is caused by a stimulus acting on an abdominal organ, the pain felt is classified as. Visceral pain arises from a stimulus, distension, inflammation, or ischemia acting on an abdominal organ. Well, let's take a look at some of our other GI problems now. I'm coming up with gastritis. Gastritis is an inflammation that occurs of the inside lining of the stomach. It can be caused, or it can be termed as either being acute gastritis or chronic gastritis, but we have an inflammation of the gastric mucosa. Notice on the left over there, we just have a little bit of an erosion. So maybe this person here's got a little bit too much acid going on in the stomach here, and they're starting to erode that inside lining of the stomach a little bit. Maybe that causes a little bit of pain. It might be a little bit of discomfort. At this point in time, we don't have any bleeding or anything like that. The next one over in the middle, it says true ulcer. Okay, now we have an ulceration that is down into some of the lower tissues, and we're into the muscle tissue and things like that. So that's going to start causing some problems, but we get into that true ulcer over on the right-hand side. Now we're down in the vascular layer, and now that person is going to have bleeding. So now this is usually, or oftentimes, the very first symptom we have is that the person starts having bleeding, and they say, well, geez, I've been noticing I've been having some stomach pain, but I thought it was just the stress at work, so I didn't think much of it, and then they come into the hospital and they've got this bleeding. This is another illustration that helps to illustrate what's going on there. At the top, you're seeing a picture of that erosion going through the different layers of the mucosa and the submucosa down to the vascular layer. That's coming off of that middle picture, showing you where that is in the stomach. And then coming down here, we're looking at a endoscopic view of that ulceration. So they actually went down with a scope, down the patient's esophagus, down through the stomach into the duodenum here, and they're looking at this ulcer by way of their endoscope, and they're able to see the ulcers, and you can see them on either side there. See the round hole in the middle, that's our duodenum, and then on either side of the duodenum there we're seeing those ulcerations. So those are ulcerations that could bleed, and obviously they need to be repaired so the patient doesn't have bleeding and pain, etc. Peptic ulcer disease is that breaker ulceration in the mucosal lining of the lower esophagus, the stomach, or the duodenum. A number of different things can contribute to the person developing an ulcer. One of the very common causes, so 98% of upper GI bleeding is caused by the patient taking non-steroidal anti-inflammatories, those are NSAIDs, or being infected with H. pylori. So those are the two main things that are going to cause people to have upper GI bleeding, is nonsteroidal anti-inflammatories and H. pylori. H. pylori is an infection of the stomach. You're not going to know who has this. People don't walk around having a name band that says, hey, I've got H. pylori, and we don't test for it. So in general, we don't test for it. There is a test that we can do to find H. pylori, but in general, we don't run around testing for it. So we're not going to know who has the H. pylori, but we will know, or we can know, who is taking NSAIDs. So you need to ask your patient about those nonsteroidal anti-inflammatories. Those are the medications like Motrin and Advil, ibuprofen, all of those medications in that category. They are used for pain and to decrease inflammation. So if my patient comes in complaining that they're having stomach pain or that they vomited up some blood at home, and they tell me that they have a history of arthritis. Okay, arthritis, what is the patient going to be taking? Nonsteroidal anti-inflammatories. All right, well then I've got a good idea here as to what's causing the patient to have that GI bleed. An increase in the amount of acid in the stomach could be the cause. There's a number of different things that increase stomach acid. One of the very common things we see in our society is caffeine intake. The more caffeine intake you have, the higher the amount of acid in the stomach. A decreased bicarbonate renewal. So bicarbonate is made so that we can reabsorb the acid in the duodenum. So, okay, let's follow this through again. Acid is pumped into the stomach to help with digestion. Then that acid flows into the duodenum. We don't want all that acid flowing throughout the entire GI tract. So what happens in the duodenum is that we pump bicarb in there to balance out the acid. We can get an autodigestion thing going on in the stomach. We could have damaged blood vessels. That's a possibility that can cause the patient to have peptic ulcer disease. But the most common causes are going to be nonsteroidal anti-inflammatories and H. pylori. The stress ulcer listed at the bottom of the page, there are a few things here that will increase the risk a patient will have a stress ulcer. One of those is a life-threatening pulmonary condition. The other is being admitted in the ICU and or having sepsis. So those are the kind of situations that usually lead to a stress ulcer. You hear people talk about that all the time. They're worried about developing a stress ulcer. Okay, a stress ulcer really is not from the stress you're going to get from nursing school. It's you may have an increase in the amount of acid in your stomach. You may be drinking more coffee than you did before. Maybe you're taking more nonsteroidal anti-inflammatories for the headaches that nursing school causes. But those things are separate from a stress ulcer. Stress ulcer is caused by having this chronic sympathetic nervous system stimulation that happens when people have severe stress, like multiple trauma, severe pulmonary illness, sepsis, and things like that. Duodenal ulcers are one of the most common types of peptic ulcers, so moving out of the stomach into the duodenum. Remember again, we have acid that is being pumped from the stomach into the duodenum. Now the duodenum is making bicarb in order to be able to reabsorb the acid, but if the person has an increase in the amount of acid that they're producing for some reason, so maybe that person is now drinking more coffee or something else that's increasing the amount of acid that's being produced in the stomach, that means more acid is dumping into the duodenum and it's going to start to erode the wall of the duodenum. Usually we get pain 2 to 3 hours after eating because we have to have full emptying of the stomach before the pain starts. With ulcers, food makes the pain better. It's after eating that the pain gets worse. Now this is different than other kinds of GI problems. In some other GI problems, food makes the pain worse. But in ulcers, food is going to make it better, at least temporarily, and then it's going to start to hurt again. I mentioned before about H. pylori infection. H. pylori infection is something that most people would not know that they have. It's estimated that about 70% of the population is infected with H. pylori. It's something we get when we're kids. We're out there playing in the sandbox with our friends, and one of them runs in and goes to the bathroom, doesn't wash his hand, and come back out, and it's an oral fecal route transmission, and we get this infection. Now, the infection lives in the stomach. You never know you got it. I mean, it's not something that usually causes any kind of symptoms unless we have some additional stressors. Okay, so let's add to the H. pylori some nonsteroidal anti-inflammatories. So here's this person. He is an athlete, and he's doing his thing here. He has some injuries, and he needs to take some nonsteroidal anti-inflammatories. but he's also infected with H. pylori. He doesn't know that because he's never had a symptom of H. pylori. So he is taking his non-steroidal anti-inflammatories, starts to develop some GI bleeding. That's how it can happen. Okay, so H. pylori usually is going to be a contributing factor rather than being the primary factor causing the patient to have the ulceration and the GI bleed. Gastric ulcers, these are occurring in the stomach itself. Usually you're going to get pain after eating fairly shortly, like within the first hour after eating, we're going to start having pain in the stomach. So again, the food is going to help. It's going to make the patient feel better until the patient moves that food onto the duodenum. Now, because there was food in the stomach, it's going to increase the stimulation of acid being produced, and now the food's gone. So we have more acid in the stomach, and the food isn't there to absorb it, and so now the patient starts to have pain. With people who have gastric ulcers, there's an increased risk of stomach cancer. This is a picture here of the inside lining of a stomach with somebody who had gastric ulcers. All those little dark spots you see there are areas where there's minor little ulcerations. Now, down toward the right side of the diagram, what you're going to see there is it's a more reddened area. So over toward the left side, it's kind of more tan and pink, and over to the right side, it's a little more reddened. So we have a little bit more erosion or just kind of general inflammation going on over the right side. You can also see from one spot to another, there's a couple little red spots on the diagram too, little areas of redness, and those are also areas that have been inflamed. So lots of inflammation going on in this stomach lining. Okay, here's another question. A 50-year-old male is experiencing reflux of chyme from the stomach. He is diagnosed with esophageal gastroreflux. This condition is caused by All right, if you answered C, you are correct. It's caused by loss of tone at the lower esophageal sphincter. Not fibrosis, not stimulation of sympathetic nerves, and not reverse peristalsis. A 60-year-old male presents with GI bleeding and abdominal pain. He reports he takes NSAIDs daily to prevent a heart attack. Tests reveal that he has a peptic ulcer. The most likely cause of his disease is correct answer is NSAIDs inhibit prostaglandins and maintenance of the mucosal barrier and decrease bicarb secretion. So NSAIDs are going to be the thing that is causing the patient to have that dysfunction. 24-year-old male who sustained a head injury and fractured femur develops a stress ulcer. A common clinical manifestation of this ulcer is bleeding. Is the most common clinical manifestation of a stress ulcer. Dumping syndrome is another one of the GI problems that is important to know about. Dumping syndrome happens because usually because the patient has had some kind of abdominal surgery. So the patient has, and oftentimes this is going to be those patients who have the reduction surgeries to the stomach. So they're having, maybe the patient has obesity and we're trying to decrease the size of the stomach so that the patient is not absorbing as much nutrients and is losing weight. So rapid emptying of chyme from a surgically created residual stomach into the small intestine, and this is a complication of your gastrectomy or pyeloplasty surgeries. Inflammatory bowel disease is a condition where the patient has an autoimmune disease process that is damaging the inside lining of the bowel. We have two different types of inflammatory bowel disease: ulcerative colitis and Crohn's disease. So these are two different kind of disease processes, but both affecting the bowel. There's a genetic piece to this. So, people oftentimes are going to inherit the characteristic of being at risk. There's some alterations that occur in the epithelial barrier functions, and maybe some reaction to the intestinal flora, and abnormal T cell responses that create this autoimmune response that results in these disease processes. So the first one, ulcerative colitis. Chronic inflammation, usually the person's about 20 to 40 years old when they're first diagnosed. It happens in the sigmoid colon and the rectum. So it's isolated to one part of the GI tract. It could be an infectious cause that started the whole process, could be autoimmune, it could be dietary. There's a genetic link piece here. The patient has diarrhea, so frequent stools, bloody stools, cramping. And so our treatment is going to be, we want to immune suppress the patient so that we can decrease some of this autoimmune response that's going on. Maybe give some antibiotics, some steroids may be necessary to decrease the immune response, and surgery may be corrective in ulcerative colitis. Remember, it's confined to the sigmoid colon and the rectum, so if we remove those, then the patient oftentimes will have their disease cured. Crohn's disease, on the other hand, again, idiopathic inflammatory disorder, can affect any part of the digestive tract. So here's one of the big problems we have with Crohn's disease is to go in and to do surgery and remove that part of the colon that's diseased, oftentimes is just going to lead to the disease popping up somewhere else. So we remove part of the colon where the disease is, it pops up somewhere else because it can happen anywhere in the digestive tract. So surgery may be palliative. I mean, it may decrease the amount of symptoms the patient's having at the time, but oftentimes surgery is not going to solve the problem. We're just simply going to get the disease back again. Again, this is an inflammatory disease, so like ulcerative colitis, we're going to have to treat the inflammation with anti-inflammatories, etc. So Crohn's disease versus ulcerative colitis, we're taking a look at some differences here in the GI tract. There's these skip lesions that happen in patients who have Crohn's disease, and the lesions are just occurring all over the place. So when you're looking at the picture of the GI tract there on the left up at the top, it's showing the GI tract, and we're seeing multiple areas, small intestine, large intestine, rectum, that are being affected at one time with this patient. So very difficult to be able to manage because it's just happening all over the place. Then we look over on the right hand side at ulcerative colitis. Again, notice it's confined to the sigmoid colon and the rectum, so it's going to be a little bit easier here to be able to manage from the standpoint of a surgical perspective. We can take it out, but obviously surgery is a last resort. We don't want to go in there and do surgery if we can avoid it at any cost. Diverticular disease is another disease that happens with the colon, and diverticuli are little outpouchings or little pockets that form in the colon, and in those pockets we can start to have some problems. There's been a lot of discussion about why diverticular disease occurs and what is the cause of diverticular disease. Well, the most common prevailing theory is that it's our low fiber diet here that causes a lot of diverticular disease. So lack of fiber in a diet is causing people then to have stool moving very slowly through the colon. As it's moving slowly through the colon's having to push harder to get that stool to move through the colon. And then in between those muscle layers, in between the muscles, stool kind of slides in between those muscle layers, like if you were to take clay and put a big wad of clay in your hand and squeeze it with your fingers, the clay would kind of seep out between your fingers. So this is what we're thinking happens that causes the diverticuli to form. So diverticulosis is just the diverticular disease. In other words, it means that the patient has those diverticuli, the little outpouchings, and there may be symptoms with that, there may not be. If there's symptoms with diverticulosis, it may be some intermittent abdominal pain, and it can also be bleeding. Diverticulitis, on the other hand, is the infectious and inflammatory stage of diverticulosis. So here are the little out pouches here. We've got the colon. You see those little things in the out pouches there. Let's take a look over, because I think the one it illustrates very well is over on the right-hand side. So if you're looking at that colon ascending there in the picture, over on the right-hand side poking out, we have one of these little diverticuli. Not only do we have an outpouching there, but that outpouching is full of stool. So stool got pushed into that outpouching. We have bacteria in there, etc., and that bacteria starts to grow, it starts to multiply, and it causes inflammation and infection in that little pocket, which then spreads outside of that little pocket to the area around the colon. That's what we call diverticulitis. So it's an inflammation and then an infection of the colon, of the area around the colon, as a result of having bacteria and etc. Pocketed in that little diverticuli. Now there's diverticuli too, just because they've kind of outpouched like that, they can also bleed. And there's the colon is very vascular, and so we could be outpouching into one of those little things there and possibly disrupt a bleeder and then cause the patient to bleed. This is a picture here of a colon with diverticulitis and lots of diverticuli sticking out of that colon. And over on the right hand side, it's showing the arrow is showing where those little pockets are pushing out. So we can see kind of the hole in the colon where that pocket pushed out. So if a 50-year-old male complains of frequently recurring abdominal pain, diarrhea, and bloody stools, a possible diagnosis could be ulcerative colitis is manifested by fever, elevated pulse rate, frequent diarrhea, urgency, obvious bloody stools, and continuous lesions in the colon. Okay, well, there's a lot of things that can cause a fever. There's a lot of things that can cause an elevated pulse rate. There's a lot of things that can cause frequent diarrhea. Even just getting a flu or getting some kind of intestinal bug can cause you to have diarrhea. So what is it that's specific about this thing here that's pointing toward ulcerative colitis? That one thing would be the obviously bloody stools. When you hear people talk about bloody, watery diarrhea, bloody, watery diarrhea, you have to think of a couple different things: inflammatory bowel disease, diverticulosis, or the possibility maybe of like a traveler's diarrhea or something like that. Okay, nothing in our little question there said anything about traveling, so I've got to think that this person here could potentially have either an inflammatory bowel disease or could have diverticulosis. Now, how are we going to make that decision? Probably by sending the patient to the CT scan and doing the CT scan. If the patient has no previous history of diverticulitis, we're probably just going to assume that maybe it's one of these two different things. We need to take a look at that colon by looking at a CT scan. Which of the following symptoms would help a healthcare provider distinguish between ulcerative colitis and Crohn disease? Malabsorption. Malabsorption is common in Crohn disease and is rare in ulcerative colitis because, again, Crohn's disease can happen anywhere in the GI tract and not just in the sigmoid colon and the rectum. So we can still have a fair amount of absorption. We can still have some very good absorption in our patient while we're having the problem occurring in the sigmoid colon and the rectum. Which disease am I? I am a chronic inflammatory disease. I tend to occur in younger people. I mainly affect the sigmoid colon and the rectum. I tend to have remissions and exacerbations. I may have a genetic cause. My symptoms include frequent, copious amounts of bloody diarrhea. With me, you see a higher colon cancer risk. All right, hopefully you got this one right off the bat, right? Because we were just talking about the differences there. So it's ulcerative colitis. Think about some key words when you think of ulcerative colitis. What makes ulcerative colitis different than Crohn's disease? Appendicitis is another GI problem. We have an inflammation, usually caused by infection, of the appendix. The appendix is a little outpouch on the colon that was originally designed years and years ago to help us to break down real complex types of foods. So assuming that we're eating a lot of meat and so on, being carnivores from back in caveman times, and the meat needs a little bit of extra digestion, the appendix was an appendage on the colon to help with that. However, we don't need our appendix anymore with the kind of diets we have, so it really isn't a necessary part of our GI tract. So appendicitis is an inflammation of that appendix, and we may have to go out and have that thing taken out. So if the patient develops appendicitis, in most cases what they're going to talk about is taking the patient to the OR. Yeah, there's a possibility of treating it with antibiotics, but if it gets infected, if it gets inflamed once, it's probably going to happen again. And rather than risk the possibility of it becoming inflamed and bursting, okay, that's the most serious complication, is the appendix becomes so inflamed and swollen that it bursts. When it bursts, it releases stool into the abdomen. Okay, now the patient's going to develop sepsis as a result of having stool in the abdomen. So we don't want to have that happen. So rather than having that occur, probably what we're going to do instead is to send the patient to the OR. Let's just go ahead and take care of this and get that appendix out. This picture here is showing the vasculature of the GI tract, or of the abdomen. So we call this thing the portal circulation. This entire vascular system that is going to innervate, or is going to vascularize rather, the liver and the stomach and the spleen and the pancreas and our GI tract, our intestine, is all called the portal system. Okay, up at the top of that portal system, we have this portal venous system draining into the liver. And if your patient has liver disease, it can put too much back pressure. So the liver starts to become swollen, it starts squeezing those vessels, and blood starts backing up in that venous system. As blood backs up in that venous system, a couple things will happen. One is there's a possibility of having little outpouchings on the veins that can burst. The second thing that happens is it's pushing fluid out of that vascular system into the abdomen, and that's what causes the patient to develop ascites. Ascites is fluid in the abdomen. This diagram here is just showing a little bit about the amount of fluid we have moving and where it's going. So coming out of the heart, we have about 7,000 mLs coming out of the heart, going down the abdominal aorta. Remember that some of that blood coming out of the heart is going to go feed the heart, go feed the lungs. So not all of it's going down the abdominal aorta. Some of it's going up to feed the brain. Cecal artery, the stomach and the spleen, you can see they're going to get some of that. The hepatic artery is going to get a good proportion, 580 mLs, and you can see the amount of blood flow starts to decrease as we get down toward the distal rectum and the colon, or the distal colon and the rectum. And then it all filters back up into that portal vein, which goes back up through the liver and then to the heart again. So the liver is filtering here on the way back to the heart. If there's liver problem, that means everything in the rest of the system is going to back up. So blood backs up into the stomach, it backs up into the intestine, backs up into the distal colon, etc. This is the problem that causes, or this is the result of that, is that the patient ends up developing portal hypertension. Portal hypertension is high blood pressure in the intestinal system in the GI tract, the GI intestinal system. Okay, consequences. And this is, the cause is usually caused by liver. So we usually have a liver problem. Either the patient has a big fatty liver, or the patient's got alcoholic cirrhosis, or maybe hepatitis, and that's causing the liver to compress those vessels. Varices. Varices are varicose veins. You ever know somebody who has varicose veins in their legs? Varicose veins in the legs happen because people are standing for prolonged periods of time. When you're standing for a prolonged period of time, gravity pulls on the vascular flow and tends to hold it down into the lower extremities. That makes those vessels start to outpouch. As they outpouch, it's going to start causing the vessels to become varicose veins. So they kind of outpouch and form into this big fat vein that's not supposed to be there. That's a varicose vein. Same thing can happen. We can get a varicose vein around the esophagus, around the stomach, or around the rectum. Around the rectum, that can cause the patient to have some rectal bleeding and can cause hemorrhoids. Around the stomach, the patient can have bleeding into the stomach, and probably one of the most significant ones here is around the lower esophagus. And this can cause the patient to have, these esophageal varices can cause the patient to have life-threatening GI bleeding. The backup of blood in the portal system also causes a swelling of the spleen, splenomegaly, and it can cause ascites. Ascites is the fluid building up in the abdomen. We're going to take a look at that here in just a moment. Lastly, we can get hepatic encephalopathy. That's caused by a lack of ammonia metabolism. This isn't a direct result of portal hypertension, it's a direct result of the liver dysfunction, but oftentimes goes hand in hand with the portal hypertension. So again, if we're looking at this vascular system here, and you're looking at that liver and say, okay, if the liver was for some reason abnormal. So let's say that our patient has liver disease, the patient has hepatitis, the liver is becoming kind of hard and shrunken down with hepatitis, and then that's causing the patient to squeeze those vessels. So the blood that's coming back up that's supposed to filter through the liver to go back to the heart is getting stuck. It's not able to filter through there, and it backs up into the vessels, causing those varices and the other problems that we talked about. Here's another picture of the problems, the results that can happen from having portal hypertension. So we can get those esophageal and gastric varices causing potential problems and possibly GI bleeds in the stomach and in the esophagus. We can also start to see some problems down there at the bottom with our hemorrhoids, with having varices or varicose veins in the rectum causing the patient to develop a hemorrhoid. Now this very busy diagram here is illustrating or talking about what happens when the patient has cirrhosis. Cirrhosis is damage to the liver. So let's go down the middle here and look at the portal hypertension part. So portal hypertension, that increase in pressure in the abdominal veins, is going to cause an increase in capillary filtration pressure, and that causes ascites. Well, there's other things that contribute to the ascites too. Cirrhosis also causes an increase in lymph production, which then adds to the ascites. More lymphatic production, more fluid in the lymphatic system, less fluid draining off from the abdomen. Decrease in hepatocytes function. So over on the right-hand side, hepatocyte failure as a result of the liver not functioning well. We have decreased albumin synthesis, which causes decreased capillary onconic pressure. Remember, albumin is one of the primary primary proteins that holds fluid in the vasculature. So that's going to cause a decrease in our effective plasma volume. In other words, it's going to cause fluid to more likely move out of the vasculature and into the tissues, in this case the tissues of the abdomen. Altered metabolism, we have an increase in renin-angiotensin and aldosterone production, which causes an increase in renal absorption of sodium and water. So we have now more water on board that also adds to the ascites. Over on the left at the bottom, we talk about bacterial peritonitis, which can cause capillary permeability. So that would be an additional complication possibly that could occur. It doesn't always occur though with cirrhosis. This is a picture here of a patient who has ascites. You can see the very distended abdomen. This is fluid in the abdomen. You see the vascular, all the veins that are showing there on the patient's abdomen as a result of all the swelling and the back pressure on the veins in the abdomen. All right, well, this is the end of the first presentation, the first piece. So let's stop here and we will continue on with part 2 of alteration in digestive function.